Hi, class. I wanted to go ahead and discuss some complex care issues, more specifically nutrition, GI, and endocrine related issues. So next week we'll start our seventh week, and I know you have a proctored test on Tuesday, and of course, I thought about possibly discussing some of this information on Tuesday, but you know how things go. Um, Many of you sometimes don't want to stick around too long after taking a fairly long test. So, and also, you guys have the final coming up in the eighth week, and of course, I want to go ahead and get this information out to you as soon as possible, um, so that you have something to study for with respect to the exam. So it's not a long lecture, actually. I can possibly finish this in less than an hour, I would suppose. Um, so we'll start off with nutrition first. We certainly know that nutrition is a very important part of the knowledge of the nurse because it is how we heal. Let's see, let me go ahead and start sharing here. Um, why does that look funny? All right. Oh, probably because my mind is kind of going back and forth to Webex versus Teams. I actually record these on Teams, so I kind of confused myself a bit. But nonetheless, all right. So I'm gonna go ahead and present. All right. So, with regard to nutrition, this chapter is going to focus on problems, or does focus on problems related to nutrition. A review of normal nutrition provides a basis for evaluating nutritional status of our patients. We need sufficient energy, protein, and other nutrients to maintain health. Um, and many of the problems affect nutrition by changing the way we are able to ingest, how we are able to absorb nutrients, digest, and metabolize nutrients. Right, and these changes can lead to malnutrition and other related to health problems, which affect functional status and the quality of life of our patients. This makes it important for nurses to be able to incorporate assessment and interventions aimed at promoting optimal nutrition so that our patients can be healthy, healthier, and heal. So these are some of the objectives I want you to take a look at when you get an opportunity. Right. Now, as you can see here, you have a number of tubes that can be used as feeding tubes. Um, so you have the nasogastric, the nasogastric tube here, and then it has a little port on this particular NG tube, the esophagostomy tube. You also have the gastrostomy. Now these are separate, of course. You have the gastrectomy tube, a gastrostomy tube rather, or G tube, and you also have the jejunostomy tube here as well. Now you'll also see in your textbook where they actually sometimes combine. They have the GJ tube or the gastrostomy jejunostomy tube. And the G part, of course, again, is the gastrostomy, and it actually decompresses the stomach. You know, all that air that fills the stomach. Well, the gastrostomy tube portion has the capability of decompressing of the stomach. And of course, the J tube or jejunostomy tube is right. It feeds directly into the small intestine, and this is of course where the actual tube feedings will take place. All right. So now, if feedings are needed for an extended period of time, tubes can be placed in the stomach, gastrostomy, as I mentioned, or the small intestine, jejunostomy. A gastrostomy tube can be placed surgically, radiologically, or endoscopically. So take a look at figure 39.7 for an example of that. Make sure I note that. And now the patient, in order to have tube feedings in the GI system, the patient must have an intact, unobstructed GI tract. All right. Otherwise, the patient cannot have the GJ tube or any kind of feeding tube. Now, enteral feedings can start within 24 hours after a surgically placed gastrostomy or jejunostomy tube without waiting for gas or flatus or a bowel movement. So once these tubes are surgically placed, of course, you have your tube feedings in the bag, and you can begin to feed these patients. And again, you don't have to wait until, in other words, what we would refer to as return of GI function, such as flatus and a bowel movement. All right. Right. So I want you all to take a look at table 3911. It does provide a great deal of information in terms of how we maintain these tubes and how we administer medications and what have you. Now, as far as nursing management of the tube feedings, something very important that we must do is check tube placement before feeding and before each drug administration. All right, because sometimes these tubes can get out of place, and so we have to make sure they're in the right place. We also want to assess for bowel sounds before feeding, because the patient can have an intestinal ileus and whatnot, and so a paralytic ileus. And so we want to know if the patient does have bowel sounds. We also want to use liquid medications rather than pills. Pills we have to crush, and sometimes if you don't crush them into that nice fine powder, then it can obstruct our feeding tube, and sometimes it may have to be even replaced, which is a whole fiasco in and of itself. Also, we want to dilute viscous liquid medications, and essentially you have some medications that are very viscous, very thick, and if you try to administer this medication in these small tubes, it can block the tube, obstruct the tube. And so what we do is we mix the viscous medication, liquid medications with water. All right. I'm trying to think of the medication. There's a protein type of medication that we give patients when they're on tube feedings, and it slips me at the moment. I can't think of it, but it's in a brown container. But at any rate, this particular medication is very thick. Even lactulose, which is what we give to patients when we want them to have a bowel movement, or um, or when we want to, well, still, it's still for them to have a bowel movement, but also for the purpose of lowering their ammonia levels. Sometimes the ammonia levels increase when the liver is not functioning well. So we give lactulose to help them have bowel movements, and so that actually brings down the ammonia levels. Do not add medications to enteral feeding formula. For example, if you got medications, not medications, but if you have the tube feedings in the bag, you don't want to add medications in the bag. All right, you administer the medications by way of a syringe, but you never want to put it in a bag. That is not how we administer medications via um, the feeding tube. All right. Let's see. Also follow measures to reduce risk of aspiration. But before that one, number four, I skipped. If using tablets, we always want to make sure the tablets are crushed to fine powder, and also that we do not crush enteric-coated medications or sustained release type of medications. We don't crush those. Those types of medications we want to perhaps get in order, or actually, as long as it's liquid, then you can ask pharmacy if they have it in that kind of preparation. They can go ahead and send it to you in a liquid form as opposed to tablet forms, if need be. As far as efforts to minimize aspiration risk, we want to keep the head of bed 30 to 45 degrees. We also want to check for residual volumes per facility policy. And what that basically means is when a patient is being fed by way of a tube in their gut, um, uh, the tube feedings is supposed to stay in certain portions of the GI tract for a certain period of time. Sometimes, if these patients are not absorbing, digesting the tube feedings very well, then there's a certain amount that can remain in the stomach. And so problems that can lead to is things like aspiration, all right? So we want to make sure, this is why having the head of bed elevated 30 to 45 degrees can be helpful as far as aiding in that digestive, process for these patients. But in your particular agency, it should provide information in terms of um, um, if the residual, let's say the policy may say if the residual is more than 150 cc's, then it might tell you to turn off the tube feedings for a certain period of time, maybe an hour, maybe a couple of hours, and then resume the tube feedings. And then by that time you hope that the residual is less than what it should be. All right. We also want to assess for complications when patients do have tube feedings, things like aspiration, obviously. There's also diarrhea, abdominal distension, hyperglycemia. We do have to check the blood sugars on these patients when they're on tube feedings. Also constipation, and as well as fecal impaction. We want to make sure these complications are minimized. All right. Now, always crush medications to fine powder, as I mentioned, and we also want to dissolve these medications in 30 to 60 cc's of purified water. If using tablets, crush drugs to a fine powder and dissolve in water in order to avoid clogging the feeding tube. It's just something you just really don't want to do. It's such a significant inconvenience, and especially for the patient. So we have to really take the time to make sure these medications are crushed very well, and that that they won't clog the tube, the tube itself. As far as the unlicensed assisted personnel, the UAP, there are certain things they can do to assist us in caring for the patient with the tube feeding. There's a section in the book, I think it is in this section, 3911. But I want you to read this section of the table, as it does inform. It informs what the UAP can do as it relates to enteral nutrition. For example, providing oral care to the patient with an NG tube, and as well as a gastrostomy and a jejunostomy tube. Also, keeping the head of bed elevated 30 to 45 degrees, and also weighing the patient who is receiving enteral nutrition. These are things that the UAP is able to perform. And of course, this is knowledge that you should have. You should know what you can safely delegate. This is all about safe delegation. You want to delegate properly to your UAPs. Let's see. I can't. There you go. As far as assessing for tube patency, all enteral feedings require routine flushing. You can't just run the tube feedings in these tubes without flushing them, because they will clog up on you. So flush feeding tubes in adults with at least 30 mLs of warm tap water. You want to do this every 4 hours during continuous feedings, or before and after each intermittent feeding. Some feedings are given continuously, meaning 24 hours around the clock. And we just have to change the bag like every 24 hours, or it may be given intermittently. The doc may have an order where it says give 500 cc's every 6 hours. And so once you give that bolus feedings, and then you just want to make sure you flush before and after. Also use sterile water in those patients who are immunocompromised, and also those who are critically ill as well. You don't want to give them water from a source where the bacteria can be detrimental to them. Always flush these tubes between each medication. And after all medications are given, we want to flush these tubes, and try to only use liquid medications, which of course I mentioned, and also just make sure that you're not mixing the medications. Mixing the medications, I mean, you never know based on what textbook says. If you give them all together, which you will find a lot, I must say. But because sometimes these patients, and I'm not making an excuse, but sometimes these patients can have as many as 15, 20, 25 pills. And to have to give each one individually, it's a lot. But one of the biggest reasons they don't want you to mix them is that if the patient has a reaction, then you want to know which one caused the reaction. What I've always thought was what was kind of off about that rationale is that, when you give medications via the GI route, it takes time to absorb, all right? And so it'll be quite some time before, the patient demonstrates some kind of adverse reaction. So, because it's not like you're going to give, let's say if you got 10 different medications to give, it's not like you're going to give one medication, wait an hour, give again, then give the other, wait an hour. You administer the first medication, you flush, you administer the next one, and then you flush, and so forth and so on. And so, I mean, how do you know in that respect? How do you know which one caused the problem? All right. Now, when a tube system is clogged, we want to flush these tubes with warm water and with a syringe, and you want to use a kind of a back and forth motion with the syringe, hopefully to dislodge the 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 tube feeding line itself. And as you can see, this can be quite inconvenient, and so it would behoove all of us when we're taking care of these patients just to make sure we flush these tubes as much as possible. So one question I would have for you all is, if the doctor ordered Tylenol and you see pills, all right, and of course they have the NG tube or some kind of tube feeding system, do you need to get an order to change it to liquid form? And so if I was to give you, let's say, a couple of minutes to think about that. So if you're changing the route of administration, for example, from pills to IV, then yes, you would. But as long as you're giving the medication by mouth, whether it's a pill, whether it's a liquid, but the same medications, because you do have Tylenol in liquid as well as pill. And so typically all you have to really do is call the pharmacist and tell them to send medication or make available medications if there's a Pyxis in the liquid form, as opposed to pills. And you don't really need an order for that. And it will make your lives so much easier. And hopefully we'll be able to preserve the feeding tube system a whole lot longer as well, if we are cognizant of this potential issue. So it's kind of that forward-looking type of process. And the other question I had, which I pretty much answered, where I'm asking, why do we flush tubes between administration of medications, and why not mix them? And of course, as I mentioned, your textbook would tell you because you don't want to put two medications together and then not know which one caused the issue. But I have my own thoughts, obviously, about that. But according to the textbook, and NCLEX, you certainly want to make sure that you give them separately. All right. Oh, I can't see my mouse for some reason. All right. So we just talked about enteral feedings. In other words, how we feed someone by way of the gut. Sometimes we cannot feed someone by way of the gut, and we have to feed them parenterally by way of IV, in other words. So parenteral nutrition is essentially the administration of nutrients directly into the bloodstream, an IV, in other words. Parenteral nutrition is used when the GI tract cannot be used for the ingestion, digestion, and absorption of essential nutrients. All right. And chapter 39-14 lists some common indications for the use of parenteral nutrition. So take a look at that. Parenteral nutrition is a relatively safe method of providing complete nutritional support. And you can find some additional information in Lewis on page 868, I believe. Hope this is updated. And also see table 13-15 for management of parenteral nutrition infusion. And that should be on page 870. Right. Now, as I mentioned, table 39-14 lists some common indications for use of parenteral nutrition, or PN. For example, if someone has severe malabsorption, meaning if you give them enteral feedings, they won't be able to absorb the tube feedings, and so that's not the preferred route. Um, Also, if there's a GI obstruction, remember the GI system has to be totally unobstructed. And also, if there are GI tract anomalies or fistulas, you cannot feed someone by way of the GI tract as well. Let's see, and there's some additional information there for you guys to read. Now, calories in parental nutrition mainly come from carbohydrates in the form of dextrose and by fat in the form of fat emulsion. All right, it looks like a white kind of a liquid, if you will. The fat emulsion looks like a kind of a white liquid. The PN or the parental nutrition itself looks more like more goldish, a golden looking color. Now, providing adequate non-protein calories in the form of glucose and fat, in other words, the reason why we give the non-protein glucose and fat is to allow the body to use the available amino acids for wound healing and of course not for energy per se. All right, so you don't want the body trying to use amino acids for energy, right? You want to make dextrose and fat available so that the body can consume those nutrients, leaving available amino acids to do what it's supposed to do. Now, as far as the composition of your TPN or parental nutrition, make sure when you guys are in the clinical setting that you look at those bags, look at the different ingredients that are in your parental nutrition. Now, the pharmacist actually adds prescribed electrolytes to the TPN, whatever those electrolytes might be, sodium, potassium, chloride, calcium, magnesium, phosphate. Also, vitamins are added, trace elements such as zinc, copper, chromium, and all this is provided in order to meet the patient's needs. Especially if you got a patient who's on quite a bit of Lasix. The pharmacist may add a little more potassium to the bag in order to help maintain their levels. We can also, the pharmacist also adds insulin to manage blood glucose levels because these patients will be on Accu-Checks Q so many hours or so, maybe usually it's every 6 hours when they're on TPN. And so they need to have their blood glucose levels monitored. All right. Now that's parenteral and more so peripheral. Well, you have two types of parenteral nutrition. You either have central or you have peripheral. If central parenteral nutrition solutions are more hypertonic. They are measuring at least about 1,600 millimoles, which is quite a bit, right? The central TPN has a high glucose content, ranging from roughly 20 to about 50%. Now, with central parental nutrition, it must be infused in a large central line vein so that you'll have rapid dilution of that solution. In other words, when someone is on a central hyperaldosteronism and because of the hypertonicity of the fluid content, if you administer this nutrition through a large vein, you have a lot of blood that is going through the larger veins, and of course, you're able to dilute the the central parenteral nutrition a whole lot better with a larger blood vessel than a smaller one. So this is why we need a much larger vein to dilute the hypertonic um, TPN solution or PN solution. Now, the use of a peripheral vein for hypertonic um, central parental nutrition peripheral parenteral nutrition can actually cause irritation as well as thrombophlebitis to the vein. It's just too strong, and so you have to dilute it more. Now, as far as the peripheral nutrition type, now it is given through a peripherally inserted catheter. It doesn't require a central line because the glucose contents are not as high. It's not as hypertonic. All right. But it is inserted. It is an inserted catheter or vascular access device into a fairly large vein as well. Now, PPN is used as far as indications for PPN when nutritional support is needed for only a short period of time. All right. Also, when protein and caloric requirements are not as high. As long as the protein and caloric requirements is not as high, then you can use the peripheral type. But the flip side of that is if the protein and caloric intake or requirements are required, then you won't be able to use the peripheral inserted catheter. Also, the risk for a central catheter is too great, which is another reason. In other words, you just can't use a central line. Maybe there's some health issue that may prevent that from happening. And also to supplement inadequate oral intake as well. Folks, I'm going to, let's see. I'm going to go off camera just for a moment. All right, students, my apologies. I had to take care of something rather quickly. All right. Now, as far as maintaining peripheral nutrition infusions, we always want to follow proper aseptic technique in order to reduce infection risk. Remember, this is a high glucose content solution, And microorganisms, they thrive on high glucose or glucose period. And so we must ensure that we're using proper aseptic technique here. We also must use a 0.22 micron filter with parenteral solutions, not containing fat, emulsion, and a 1.2 micron filter with solutions containing fat emulsions. And let me show you all. Let's see. This is a filter here, and you connect this to a regular line that your actual TPN will be used as well. But it has like a Lura lock kind of a function to it, and this just captures those particles that could become more or less like an embolism. All right. And so this is what we use. So I just want to give you an idea of what that will look like. This is another one actually here. I have seen actually both of these types of filters. All right, so just give you an idea what that looks like. Let me go back. All right. Also, we must change the filters and the IV tubing with each new peripheral nutrition or parental nutrition container, or every 24 hours. Usually, it's every 24 hours. Typically, TPN and lipids run. It runs every 24 hours, and so around roughly 7:30, 8 o'clock. Pharmacy will send up a new bag, tubing, filters, and everything, and then you have to take the old down and then put up the new. You don't want to leave them up for more than 24 hours because of, again, infectious risk. All right, and so they usually changed, of course, in the evening or the evening shift would normally change it. It's roughly about 8 o'clock, 8 p.m. All right. Now, we also must label tubing and the filter with the date and time they are put into use, because we want to remind each other that, hey, this has been up there too long. We need to change the tubing to lower the patient's risk of infection. Let's see. If a multi-lumen catheter is present, you have like your triple lumen catheters. You want to use a dedicated line for peripheral nutrition. And for those of you who perhaps need a visual, let me see if I can provide one. Triple lumen catheter. I want to. Oh. Well, so this is, let's see. So this would be like a triple lumen catheter, right? A multiple lumen. Sometimes it may just be a two lumen device as well. But this is this particular one is 3. Or like here, you have the proximal one, you have the distal one, you have also the medial line portion. I want to say we use the distal port for the TPN, but I would have to go back and double check that. But you always want, let's say, for example, if it's the proximal port, what they're saying is you just have a dedicated line for the TPN, all right? You don't have TPN, heparin, antibiotics, this and that, and or the other. You want to have just a dedicated line. And if you have to, you want to try not to draw blood from that dedicated line as well. Sometimes it's the only line that may be available. The other 2 might be clogged up for whatever reason. And this is the only one that will give you some blood. you know, if you join your labs for your patients. And so what we do in these cases is we flush with maybe, let's say, 10 cc's of normal saline, and then we draw back as a waste 10 cc's of blood. Excuse me. So we discard that, and then we take an empty syringe, and then we draw our sample. Let's say if you need 5 cc's of blood, you draw your 5 cc's of blood. You cap it. Well, not cap it as in a needle cap, but you cap it with some capping device, and then you go ahead and flush it with 10 cc's of normal saline, and then resume the TPN. All right. And if we don't flush these normally, like we're supposed to, they tend to go bad, unfortunately, and clog up. All right, let's see. I think that's all for that one. All right, let me go ahead and present again. I'm trying to give you guys as many examples as I possibly can, because sometimes you just need that visual to help you to capture the essence of the discussion. All right. So in your textbook, table 39-16, it talks about the different complications of parenteral nutrition. You have the metabolic problems with this problem. Or the complications you have, in other words, refeeding syndrome. We'll talk about that. You also have hyperglycemia or hypoglycemia. Usually, let's say if the TPN maybe some of it got wasted, and the current bag is not enough to get you to the next tube feeding. Let's say if it runs out at 5 o'clock in the evening instead of around 8 o'clock or beyond. And so we can't just abruptly just let the tube feedings or the not tube feedings, the parental nutrition feedings just run out, because then the patient's blood sugars can decrease significantly. So in these cases, we place them on, let's say, IV D10. Dextrose 10. It's just a glucose solution. Now, on the other hand, sometimes these patients, they may not handle the TPN very well, and the glucose levels are through the roof. So they can suffer from both either hyper or hypoglycemia. So just kind of give you those examples. But the hyperglycemia, when we know that blood sugars are running fairly high, we're not only checking the blood sugars often and administering regular fast-acting insulin, but we may also add some insulin to the bag, all right, to aid in the management of the glucose levels. There's also altered renal function as far as one of the problems that you might see. There's also essential fatty acid deficiency, not enough fat to break down and use. Remember, you want to use fat and dextrose as a source of energy as opposed to the amino acids. Also, there can be liver dysfunction and as well as hyperlipidemia, especially the hyperlipidemia as it relates to the fat emulsion, that white substance. I don't know if, let's see if I can get you guys so let's see, TPN and fat emulsion. So here's what it pretty much would look like. You see the lipids here, the fat emulsion, or intralipids is what we may call it. And here is what we would typically see as well. your emulsion can come in both, either a bag or usually we use the bottle, but it can come in a bag. But this is your parenteral nutrition here, all right? That's golden looking, almost looks like urine actually, right? And sometimes it may tell you on the bag for central line use only. All right, so let me kind of back up on that one a bit. So if you have peripheral nutrition, the one with the least or a lower amount of dextrose, if you will, or less hypertonic, you can, of course, infuse that through a peripheral line, right? But you can also infuse that same solution through a central line, all right? And of course, it is because that central line is able to handle a lower glucose level. So you can infuse peripheral through a peripheral and a central line. However, you cannot infuse central TPN through a peripheral line. The central type, which is very hypertonic, has to go through a central line, as I mentioned, but it cannot go into a peripheral line. So just make sure you understand that. Yeah, keep that in mind. And like I said, it should have like a central. It should say central line only. And if it says that, you cannot infuse this into a peripheral line. All right. Let's see. And then you have the catheter-related problems, such as an air embolism. So you want to always make sure you get all the bubbles out, right? And then as far as inserting the catheter, there's a needle that is used in the process of the physician inserting a central line. So you have this needle can cause a pneumothorax, a hemothorax, or a hydrothorax. And so this is why we check the chest X-ray to make sure that there's not a pneumo of any type. There can also be hemorrhage. I mean, you're going into a large vascular system, a vein. The tube feeding system or the catheter can become dislodged. It may not be in the right place. Thrombosis of the vein can occur, phlebitis, of course, catheter related to sepsis, which is why we use aseptic technique, as well as occlusion can occur as well if the veins lumen is not as large. Now, as far as that refeeding syndrome, something you need to know about, it can occur anytime a malnourished patient starts aggressive nutritional support. It is characterized by fluid retention and electrolyte imbalances. The imbalances on the low side. In other words, the phosphorus, potassium, and the magnesium levels would be lower with refeeding syndrome. Now, hypophosphatemia, low phosphate levels, is actually the hallmark of a refeeding syndrome and is associated with serious outcomes, including cardiac dysrhythmia, so place these patients on the monitor, respiratory arrest, and also neurologic disturbances such as paresthesia. Now, conditions that predispose patients to refeeding syndrome include long-standing malnutritional states, such as chronic alcoholism, they don't eat, vomiting, diarrhea, chemotherapy, as well as certain major surgeries. Now, refeeding syndrome can occur anytime a malnourished patient starts aggressive nutritional support. And I actually talked about that already. But yeah, so that would be some of the biggest reasons you will find this to be an issue. Let's see. I'm going to this out. All right. Let's see, where are we? All right. So we talked about oh, I almost thought I didn't put my cap on my water. Um, so we talked about some nutritional concerns, assessment, interventions, if you will. So let's now turn our attention to some of the intestinal disorders. There can be gastrointestinal disorders that involve the esophagus. Also, we have to consider peptic ulcer development only in an acid environment, when there's a lot of hydrochloric acid that is being produced. There's also Helicobacter pylori, medication-induced injury to the GI system. There's certain lifestyle factors, such as alcohol use. There's gastric ulcers, duodenal ulcers, and also stress-related mucosal disease as well. Some of the biggest complications that can occur due to these types of GI disorders is hemorrhage and perforation, because the mucosa is going to be compromised, and it is compromised, especially when we're talking about ulcers. There are also some surgical interventions and post-op care that is important to know as well. And also post-gastrectomy dumping syndrome. We'll talk about that as well, something that can be found on page 917. Now, no matter what the cause of the GI disorder, we have to keep in mind that nutritional deficit is likely. All right. Now, a nutritional assessment is warranted to identify those at-risk clients or patients, and a dietitian consult should be considered as well. This is all a part of the interprofessional collaborative effort, right? Now, the condition can likely result in the need for surgery. Sometimes these patients might need surgery because perhaps they're bleeding, or if there's a perforation that needs repair, if you will. Now, some complications to look for with these patients are, for example, hemorrhage and perforation. And so in this case, you want to look for an abdomen that is hard and rigid. You also want to look for signs and symptoms of shock because they are bleeding at this point. Also anorexia, nausea and vomiting. Obviously, there's going to be unstable vital signs as well with these patients because they are going into shock. All right. Now, surgical intervention can vary, as well as the post-op care, depending on what the surgery is, right? Many of these patients will require an NG tube for decompression of the abdomen. And one very important thing we have to keep in mind about an NG tube is that it cannot be manipulated. All right. You have to leave it in as is by the surgeon. All right. Now, when we decompress the abdomen, this decreases pressure. You develop all this edema and all this air in the stomach, And of course, the NG tube would decompress the stomach and relieve it of all the air. So then you have less pressure on the suture lines, and it allows edema and inflammation resulting from surgical trauma to resolve. All right. We want to ensure that we measure the output and describe the drainage as well. We also want to look for the possibility of bright red blood drainage, right? Small volumes of bloody drainage from the NG tube can be expected for the first 2 to 3 hours because of bleeding at the anastomotic site is pretty common. Anything beyond that, then there's cause for concern. We also want to observe for fluids and electrolytes. We want to look at the acids and bases, so we're looking at the ABGs. Also preventing any respiratory complications, maintaining comfort, and also preventing infection are goals or outcomes that we're looking for. Now, some of the complications after GI surgery would include atelectasis, pneumonia. There can also be a leak at the anastomosis site as well. These patients can also develop DVTs, pulmonary embolism because of immobility, as well as bleeding. Now, we always want to closely observe the patient for an anastomotic leak and notify the healthcare team once one is suspected. All right. We also want to observe the NG tube closely because blood easily collects in that system and clots, and it can clog the feeding or the NG tube. Whatever type of tube that is being used. If this happens, we want to notify the healthcare team immediately if the tube stops draining or if it appears obstructed with blood. We want to notify the team so we can intervene as soon as possible. We also want to give pain medications as needed, but we should be aware that pain can come from the fact that the patient may have an anastomotic leak rather than the typical surgical pain. And so we have to be able to distinguish between the two. Because the surgical pain, of course, the remedy for it is, in all likelihood, pain medications. But with an anastomotic leak, this will require a surgical repair. So the patient may have to go back to the operating room. Now, the abdominal wounds also need frequent observation for the amount and type of drainage, condition of the incision, and also signs of infection as well. Now, as far as dumping, post-op gastrectomy, dumping syndrome, dumping syndrome can also be seen in your patients who have certain bariatric surgeries and whatnot. But if the stomach has to be removed, let's say for cancer of the stomach or something like that, this dumping syndrome, it is the direct result of surgical removal of a large part of the stomach and the pyloric sphincter. Remember, the pyloric sphincter is at the portion of the stomach that leads into the duodenum, or the first portion of the small intestine. That shows a pyloric sphincter, which can be removed and, of course, result in dumping syndrome. Now, normally, if you think about this, think about your anatomy and physiology, or the normal anatomy and physiology. Normally, gastric chyme, that's the breakdown of all that food that you're eating mixed with other things like gastric acid or hydrochloric acid. But anyhow, gastric chyme enters the small intestine in small amounts, all right, as long as you have an intact stomach and a lower intestine and pyloric sphincter and so forth. However, after surgery, the stomach no longer has control over the amount of gastric chyme that will be entering the small intestine. Therefore, a large bolus of hypertonic fluid enters into the intestine. You know that the foods or the chyme that is coming from, or that would have usually been in the stomach, where it comes directly into the small intestine, and this solution is very hypertonic. Um, and as it enters the intestine, um, because it is hypertonic, it tends to pull fluid from the essentially the vascular system um, into the bowel itself, the small intestine. It pulls all that fluid from the vascular space into the small intestine. And this creates a decrease in the plasma volume. Um, Also distension of the bowel lumen, and also there's this rapid transient, intestinal transient. This food is just moving really fast through the system, whereas I should say typically it goes in small amounts, but this time it's going in much faster pace because the stomach is essentially gone, and the pyloric sphincter is gone as well. All right. So again, because of the hypertonic solution that is in the small intestine, it is going to pull those fluids from the plasma volume, and this leaves our vascular system a little more depleted of vascular fluid volume, and of course what to the blood pressure. It drops it. It makes the blood pressure lower. All right. So these patients become hypotensive as a result. Right. Now, these symptoms usually begin within 15 to 30 minutes after eating. The patient usually describes feelings of generalized weakness and sweating, palpitations, and dizziness as well. And these symptoms are due to that sudden decrease in the plasma volume, all right, because that hypertonic solution is going to pull it. The patient may also have abdominal cramps, and they may also develop what we call borborygmi, something like that. It's Borygmi. And basically, this is an audible abdominal sounds made by the hyperactive intestinal peristalsis that you hear on with the stethoscope. They'll also have the urge to defecate with dumping syndrome. Now, these manifestations or symptoms typically last for less than about an hour after eating. And typically, a short rest period after each meal reduces the chances of dumping syndrome. Sometimes they might tell patients to lie down after they eat, and hopefully this rest period will help reduce this phenomenon from occurring. All right, so that's our GI disorders. The next section here that I want you to take a look at. Some of the rest of some of these endocrine disorders, you guys should have already had, and so we'll discuss them briefly here just to give you an idea of how they relate to complex health care type of patients. So, as you all should know, you should know that with hyper and hypothyroidism, we're talking about either an increase in the amount of thyroid hormone or a decrease in the amount of the thyroid hormone. Now, as you can see here in this image, you have this concept referred to as euthyroid. All right, euthyroid is essentially a normal functioning thyroid. All right, that's what we want. That's what we want to achieve. Now, with hyper and hypothyroidism, as you can see, well, the patient will have either one. But again, the goal would be to get them in the center, euthyroid or normal thyroid. All right. Now, what you're looking at here also is a couple of complications that result from either hypothyroidism, which is myxedema coma, or hyperthyroidism. The complication would be thyroid toxicosis or thyroid storm. All right. All right. So you're looking at two extremes here. Again, the hypothyroidism or the thyroid toxicosis or the hypothyroidism, myxedema coma. Again, the goal is to achieve normal euthyroid. Now, if the patient has hyperthyroidism, they may require a medication called PTU, or they may require the removal of the thyroid. Now, with surgery, it is always possible to inadvertently remove the parathyroid gland. As you know, the parathyroid gland controls the phosphorus and calcium levels. And since the neck is being operated on, we also have to think about airway obstruction from edema in the neck region. And another consideration, if the parathyroid is inadvertently removed, the patient may exhibit signs and symptoms of hypocalcemia. Because remember, the parathyroid glands help to maintain the calcium levels. And of course, when you have a hypofunction parathyroid gland, it won't be able to maintain the calcium, and so you have hypocalcemia. And so whenever you think about hypocalcemia, think about the two different tests that we do to determine if the calcium levels are low, and that is the Trousseau sign and the Chabos-Tech sign. All right. Give you all an idea of what that looks like. What I want you to do as well is to look at one of the YouTube videos on how to conduct each of these tests. And it's just basically tests that can easily detect. Let's see. Well, let's see. So it's probably better to just do YouTube video. So I won't let it play all out, but if you go ahead and type in Trousseau sign and Chabos-Tech, let's see. And sometimes I get a little confused about which one is which. So the Chabos-Tech sign is twitching of the facial muscles in response to tapping over the area of the facial nerve. So the clinician will take their finger and they'll brush up against the facial muscle, and it'll twitch, right? And see, they're not that long. But the Trousseau sign is when you take a blood pressure cuff, you inflate it, and then it will create this kind of spasm of the hand. And all of these are just indications of low calcium levels. I mean, yeah, you're going to eventually get calcium levels as far as drawing blood for your labs. But if you want a quick, ready results, then one of the early indications is either a positive Chevostek or Trousseau sign. All right, kind of give you an idea there. Now, of course, when someone has hypothyroidism, the proper treatment is typically administration of Synthroid or synthetic thyroid hormone. Now, as far as hypothyroidism, the complication is myxedema coma, or we also refer to it as a hypothyroid crisis. Now, this occurs when when hypothyroid is poorly treated. All right. So when these patients are poorly treated, this complication can occur, or if it's not treated at all, if it's either under treatment or not treated at all. And this particular complication does carry a 60% mortality rate, so that's pretty high. Other possible contributing factors to myxedema coma is acute illness, surgery, chemotherapy, and so forth. Now, issues that occur with myxedema coma is that these patients can go into a coma. They experience respiratory failure, which is what kills them mostly, hypotension, hyponatremia, hypothermia, as well as hypoglycemia. These are the issues that you will see when someone goes into myxedema coma. The metabolism is also significantly decreased, and so even the muscles of the heart is not working like they should, and therefore the heart becomes more flabby. The heart chambers will also begin to increase in size, and because of that flabbiness and that increasing size of the chambers, it will eventually lead to a low cardiac output with, of course, decreased perfusion and gas exchange to, of course, your brain and to your vital organs and tissues. So in this case, you can even just start thinking about more or less heart failure and the perfusion issues that ensues. And so you have this decreased cellular metabolism that is just basically worsening, and it will eventually lead to other tissue and organ failure because, again, you have that low cardiac output that is occurring, low heart rate, low cardiac output, low blood pressure, and so, again, that perfusion issue. All right. It can also be caused by myxedema coma, that is, can be caused by other events, drugs, a variety of conditions. So the most common cause of death with myxedema coma is going to be respiratory failure. If someone is in myxedema coma, which is severe, IV medications will likely be administered. I mean, you won't just go in and give them PO Synthroid. You'll likely give them the IV type, right? And then you also have hyperthyroidism, and this complication is thyrotoxicosis. Typically, people with thyroid disorders, they're managed in the community, but there are times when these patients will require acute level of care. And especially if they go into this particular complication, thyrotoxicosis, or also what we call a thyroid storm. Now, as far as history is concerned, these patients with hyperthyroidism, they may report unexplained weight loss. And this is, of course, because there's an increased metabolic rate that affects the patient's nutrition. There's also an increase in appetite. I mean, they're burning up everything, proteins and carbohydrates and fat and just everything. They're just burning it up. No matter how much they eat, they're just burning it all up. So you also have increased bowel movements. Now, keep in mind as I talk about this, whatever I'm saying about as far as these symptoms or what these patients may report, Um, think about the opposite for hypothyroidism. So right now we're discussing hyperthyroidism and the effects it has on the body. And so if there's an increase in appetite for hyperthyroidism, then for hypothyroidism, there's going to be maybe anorexia. Instead of having increase in bowel movements that you will see in hyperthyroidism, you see more of constipation in hypothyroidism. Or as far as gaining weight, or rather losing a lot of weight in hyperthyroidism, you will see a loss of gaining weight, excuse me, and hypothyroidism. So just think about the opposite. Whenever you look at some of these endocrine disorders, they're just opposite in their symptomology or clinical manifestations. All right. Now, these patients, of course, we have to really increase their carbohydrates, their calories, their proteins, in order to try to help maintain their weight, and of course, try to get them back to that euthyroid state as soon as possible. Now, the hallmark sign of hyperthyroidism is heat intolerance. So it's heat intolerance for hyperthyroidism, but it's cold intolerance for hypothyroidism. All right. Now, these patients, when they have this heat intolerance going on, they may have increased sweating, even if the environmental temperature is comfortable for most other folks. These patients might be seen wearing light clothing, even in cold weather. They may have a wife beater on or something like that. Because they're burning up. I mean, their metabolism is just really burning out of control, and so they're really hot, right? And so they could be outside in a tank top, and it's about 30 degrees outside, and you're looking at them like they're crazy, right? Um, so the term thyrotoxicosis essentially refers to the physiologic effects or clinical syndrome of that hypermetabolism resulting from excess circulating levels of T3 to T4 or both. Essentially, a lot of thyroid hormones are circulating. And so that positive negative feedback loop may not be working for whatever reason. Now, in acute thyrotoxicosis, all of the symptoms of hyperthyroidism are very prominent, and they can be very severe as well. Some clinical manifestations also can include severe tachycardia, heart failure, shock, and also hyperthermia. The temperature is really elevated. It can go up as high as 106 degrees Fahrenheit. These patients also become agitated, they become delirious, they have seizures, abdominal pain, vomiting, diarrhea, as well as coma. This one can lead to a coma as well. There are some first-line medications, anti-thyroid drugs that are used. One is called tapazole or methimazole. The other is propylthiouracil, something like that. And these drugs inhibit thyroid hormone synthesis because there's a lot of thyroid hormone circulating throughout the body. And of course, these medications inhibit the production of the hormone itself. All right, and so now we want to turn our attention to some of the other endocrine disorders. As you can see here, you have Addison's disease and Cushing's disease, and those are just two opposites. It involves the adrenal glands, the cortex in particular. Of course, you have your thyroid storm, which we just discussed with the increased levels of thyroid hormones or hyperthyroidism. We also have DI and SIADH. I'm kind of just pairing them because they're essentially opposites. And then you have DKA and HHS, hyperosmolar syndrome. Um, Now, in order to understand what is actually happening here with some of these disorders, you have to go back, and hopefully you guys remember when you studied this information in previous Med-Surg courses. Of course, now we're dealing with having these conditions, of course, in a more complex patient. But hopefully you do remember quite a bit of the information that you learned back then. I mean, I will do a bit of a review, but you may just have to go back and do a little more reading in this regard. So when you think about the adrenal gland, remember as far as the anatomy, you have the middle portion of the adrenal gland, and that is the medulla, and that produces your epi, norepi, or your catecholamines. And then you have the outer portion, which is the cortex. And of course, that deals with your sex hormones or androgens. It deals with your salt hormones or aldosterone. And it also deals with your stress hormones, such as your cortisol or glucocorticoids, which is helpful in times of stress. All right. Now, adrenal corticosteroids may decrease from inadequate secretion of the ACTH. Remember, the anterior portion of the pituitary gland, it produces ACTH, which this stimulatory hormone travels to the adrenal glands in order to stimulate it to produce those different hormones that I just mentioned, the cortisol and the aldosterone, which is the salt hormone, and the sex hormones. Now, it can also be from dysfunction of the hypothalamic pituitary control mechanism. Remember, the hypothalamus and the anterior and posterior pituitary gland work together. All right, and if the pituitary hypothalamic pituitary mechanism is not operating well, then you're not going to the body will not be able to stimulate or create the ACTH that is used to stimulate the adrenal cortex to produce the different hormones. So, in other words, the problem can be at that level. All right. And then the problem can be that there can be a problem with the adrenal gland tissue itself. And so even though enough ACT is being created, if the tissues are dysfunctional or diseased, the adrenal gland tissue, and it cannot respond to the ACTH, then you're not going to have this production of the cortisol, the aldosterone, and the androgen or sex hormones. All right. Now, signs and symptoms can occur rather either gradually or can occur quickly, especially when stress is involved. Acute adrenal cortical insufficiency or adrenal crisis is life-threatening. Signs and symptoms that occur, it can occur without warning. And so behooves you to really understand this disease process. Now, when there is deficient adrenal corticosteroids, problems occur because of, for example, loss of aldosterone. If you can't produce aldosterone, which is the salt hormone, remember the aldosterone stimulates the kidneys to absorb sodium, and of course, what follows sodium is water. And as long as you have an adequate amount of salt and water in the vascular system, then you have a good blood pressure. But when you have a deficient amount of these hormones, then aldosterone cannot be created in sufficient supply, which means that it cannot stimulate the kidneys to reabsorb sodium and water. And so what happens is that sodium in water is actually lost. And if the sodium in water is lost, then the intravascular volume is also diminished or decreased. And if that is decreased, then your blood pressure will also be decreased, which is one of the symptoms of this condition. So with the cortisol, there's also loss of cortisol production as well. With low levels of cortisol, those glucocorticoids, it helps to maintain your blood glucose levels as well. All right. But hypoglycemia will occur if there's deficient ACTH. All right. And there's also a decrease in gastric acid production as well as glomerular filtration as well. Now, when these patients have a decrease in glomerular filtration, this is going to lead to an increase in the BUN, all right? Which will also in turn, as the BUN increases, this will also lead to anorexia and weight loss as well. And as I said, as far as the decreased aldosterone secretion, this is going to lead to a disturbance in the fluid and electrolyte balance. Potassium is typically going to be decreased. The excretion of potassium is going to be decreased. All right, in this case, and of course, this is going to lead to hypercalcemia, hyperkalemia. I'm sorry, high levels of potassium. And then you have this, while you're holding on to potassium, you're getting rid of your sodium and water. There's going to be an increase in sodium and water excretion, and this is going to lead to hyponatremia, low sodium levels. And also what follows salt, when the salt is excreted, then fluids are going to be excreted as well. And so you have this hypovolemia, or low blood pressure, as I mentioned. Now, as potassium increases, the hydrogen ions are going to be increased as well, and these patients are going to be in a more acidotic state, right? Because more hydrogen ions in the blood leads to acidosis, right? And then, of course, with the decreased production or response to ACTH, whatever the reason is for the hypoadrenalism, you have these low adrenal androgen levels as well. Now, what this means is there's going to be decreased sex hormones available, so the patients will have a decreased body, axillary, and pubic hair. All right, especially women, as the adrenals produce more androgens in females, and so they will have decreased hair. So the opposite of this would be, in terms of hyperadrenalism, would be increase in body hair, axillary, pubic hair. So just again, think about the opposites. If you learn one very well, then the other is just the opposite. All right. Now, the greater the degree of hormone deficiency, the more severe the signs and symptoms are going to be. All right. And then you have the, of course, you have Addison's disease, or, well, it's essentially what we've been talking about. You have, it's called Addison's disease or adrenal insufficiency. And of course, it can be classified as a primary or secondary type. All right. Now, a common cause of secondary adrenal insufficiency, and I want you to think about this. If somebody is receiving glucocorticoids, some form of a steroid, a synthetic type of steroid, and then you suddenly take it away. In other words, you don't wean it. this can actually lead to a much lower production of the glucocorticoids. All right. Essentially, sudden cessation of long-term glucocorticoid treatments is what we're talking about here. So you cannot DC this synthetic type suddenly. You have to do it incrementally so that the patient's own body can produce its own endogenous glucocorticoids, right? When somebody is receiving the synthetic type, it actually suppresses the production of glucocorticoids through what we call a negative feedback mechanism. In other words, if you're giving someone an exogenous or a synthetic form of a steroid, their or this person's adrenal glands is not going to be producing its own glucocorticoids, all right? Because the synthetic version is saying there's enough. And if there's enough, that means that the negative feedback loop kicks in and says, you don't have to produce any more. Well, the reason why we have to gradually wean someone off of steroids is so that as you are weaning, the positive feedback loop kicks in and says, all right, instead of being at 100%, you're at 80%. So we'll make up the difference. And then as each time you reduce the synthetic type, the human body produces more of its own endogenous or natural glucocorticoids. And I hope that makes sense to you all. It's that positive and negative feedback loop. The negative feedback loop kicks in when there's enough, but if levels begin to fall, then the positive feedback loop will kick in and it tells the system to produce. All right. So with Addisonian crisis or this acute adrenal deficiency, again, it is a life-threatening event. The body needs more cortisol and aldosterone greater than what the body can actually supply. All right. With the Addisonian crisis and/or acute adrenal deficiency, it occurs in response to a stressful event. It could be surgery, trauma, a severe infection, especially with a decreased adrenal hormone output. You're not putting out as much of these different hormones in the adrenal gland. Without treatment, the sodium levels will fall, the potassium levels will increase, and because you have this loss of aldosterone, these patients will have severe hypotension from volume depletion. All right. So again, remember, when you have the hypofunction of the adrenal gland, the aldosterone is not going to tell the kidneys to hold on to sodium in water. In other words, you'll be excreting sodium in water, and your blood pressure would be lower, and your potassium level will also be increased in this case. So you have hyperkalemia, and you have hyponatremia and hypovolemia in this case. Because the potassium levels are increased, dysrhythmias are possible with the irregular heart rate, even cardiac arrest. And so we want to place these patients on monitors and, of course, take measures to decrease the potassium level. Treatment is usually to give these patients glucocorticoids, giving them steroids. All right. And then we have decreased sodium levels, which can lead to hypotension. And of course, those hyponatremia or natremic symptoms. altered cognition, which is actually the first indicator of adrenal insufficiency. All right, and then we have the hyperfunction of the adrenal gland, or Cushing's. You just have this hyper secretion. It's kind of like giving a patient a lot of synthetic steroids. All right. The things we talked about for hypofunction of the adrenal gland, now you'll begin to see the opposite, right? Now, and we also call it hypercortisolism. You know, cortisol levels are pretty much through the roof, or Cushing syndrome. And it basically means that there's an excessive secretion of cortisol from the adrenal cortex, not the medulla, but from the cortex. And this causes many health concerns for these patients. Now, the problem can come from either there could be problems within the adrenal cortex itself. Maybe the tissue cannot respond to ACTH. Or there can be issues in the pituitary gland, because remember, the pituitary gland secretes the ACTH, which travels to the cortex of the adrenal gland. Or it can be a problem with the hypothalamus. Remember, because the hypothalamus has an influence over the pituitary gland. Again, this goes all the way back to your endocrine disorders. So just trying to give you as quick a down and dirty review as possible. Now, whenever the body has excess glucocorticoids, no matter what the reason is, metabolism and all body systems are going to be impacted. The reason why you see a characteristic kind of truncal obesity or buffalo hump, which I'll show you an example of that here shortly, or moon face, is due to fat redistribution that occurs with this disorder. There's also an increased breakdown of tissue protein that will lead to loss of muscle mass. And of course, with loss of muscle mass, you have decrease in muscle strength. The skin becomes also thin, and also the capillaries become pretty fragile. Now, this condition also has an effect on minerals, leading to bone density loss, hence can result in bone fractures when you have low bone density. And so, of course, with these patients, you always want to handle them with care because their bones are fragile. For example, if you're pulling them up in bed, you don't grab them by the arms. You use a draw sheet to maneuver them in the bed, so you don't cause any damage, further damage. Right. Now, immunity is reduced as well, because when levels of corticosteroids rather, are increased, this actually leads to a decreased production of lymphocytes. It shrinks organs that contains lymphocytes, such as the spleen, the lymph nodes, and it also has an effect on white blood cell cytokine production, which is going to be decreased. And all of this is to say that these patients are going to be at increased risk for infection. Right? Increased glucose levels just has this kind of impact on the immune system. Androgen production is also going to be increased because we're talking about Cushing's or hypersecretion of these hormones. And so androgen production is going to be increased with, again, what we call hypercortisolism. And this is going to lead to acne, hirsutism, as well as clitoral hypertrophy. The androgen production will or can also cause a disruption of the normal ovarian hormone feedback mechanism. So then there's decreased ovarian production of estrogen and progesterone, which can result in scant or infrequent menses, right? All right, so that's dealing with that completes the adrenal gland. And then, so we get into diabetes insipidus. So, with diabetes insipidus, there's increased volumes of urine that is being lost, as opposed to SIADH. You're holding on to a lot of that volume. Now, with DI, there's going to be that increased excretion of urine, and this is due to the fact that the distal kidney tubules and the collecting ducts are not able to absorb water. Remember that ADH is not working. ADH is that anti-diuretic against diuresis hormone, against you know if it's anti-diuretic, it's against diuresis, is what I'm trying to get over to you. All right. And so if the ADH is not working for whatever reason, maybe there's a hair trauma, there's something going on at the posterior portion of the pituitary gland, maybe the hypothalamus is not working, maybe the kidneys are not able to respond to the kidney tissues because maybe the patient is in renal failure, but they're not able to respond to the ADH. But whatever the reason, if the ADH is, let's say, low in production, you're not going to have this reabsorption of water. All right, there's more excretion than absorption. It leads to polyuria or excessive water loss through urination, which will in turn lead to what? Dehydration, right? And also the fluid and electrolytes are going to be disturbed as well. That fluid and electrolyte is going to be disturbed because, again, the ADH is not functioning, or whatever the other reasons might be. Now, dehydration from massive water loss will cause the plasma osmolarity and sodium levels to be increased. Remember, you're losing all that volume through urine, and so your blood plasma is going to be more concentrated, all right? The sodium levels are going to also be increased because you have less fluid volume. Now, this is going to be opposite with the SIADH, right? So sort of kind of as we talk about it, we might as well include that one as well. And so now with SIADH, you're holding on to all that fluid, right? And so the sodium becomes more dilute. And these patients have a chance of becoming fluid volume overloaded, all right? But there's fluid volume depletion for DI. All right. So anyway, so you have this increased plasma osmolarity and also sodium levels are going to be increased. And this is going to cause these patients to become thirsty, which is going to lead them to drink increasing fluids. And this can actually help them maintain their hydration status as long as they're able to continue to drink. They would be able to hopefully dilute or to hydrate again. But now, if they're not able to drink, of course, this is going to lead to severe dehydration and death. Now, drugs that interfere with response of the kidneys to ADH, causing DI, are medications such as lithium and demeclocycline. Those are the two medications that can interfere with ADH and cause these patients to urinate excessive amounts of urine. As far as assessment is concerned, We want to always ask these patients about any recent surgeries, any head trauma, medications, because all these can contribute to DI. Shock may ensue if these patients cannot drink enough water, so we have to really be monitoring them. Now, water loss changes the blood and the urine tests. A 24-hour urine test is done, um, and of course, this is done without restricting any fluids or food. If someone presents with DI, they may have a greater than 4 liters of urine output during this period. Um, and they're excreting more than they can actually ingest, and so we have to make sure that they are able to take in more fluids. Now, some patients with DI may excrete 4 to 30 liters per day, and of course, with all the getting rid of so much fluid in the urine, it will cause the urine to be more diluted rather than concentrated, or the osmolarity is going to be more decreased, like less than 1.005, again, because it's more diluted. The serum osmolarity might also be extremely low, between 50 and 200. And that's pretty significant. The normal range for serum osmolarity is between roughly 260-ish, 270 to about 300. And so that would be pretty low. Now, of course, osmolarity, it just refers to the concentration of dissolved particles of chemicals and minerals, such as sodium and other electrolytes, in the patient's serum. Higher osmolality just means more particles in your serum, and lower osmolarity means it's more diluted. Now, as far as DI interventions, drug treatment is used to manage DI, mostly desmopressin or DDAVP is going to be used. Now, the synthetic form or vasopressin is given sublingual or allowed to melt under the tongue, or it can be given intranasally in metered spray. And the doses vary depending on the severity of the condition. The more severe the condition, the more doses is going to be required per day. Now, if DI is severe, then IV or IM might be required as well. Now, for the nasal spray type, as far as side effects are concerned, think about ulcerations of the mouth, allergies, chest tightness, and long inhalation of spray may also occur. Now, for patients with side effects or upper respiratory infection, you want to give this medication either orally or sub-Q. In the hospital, the nurse must be able to detect dehydration early and also maintain hydration. And so we want to do accurate intake and output, check the urine-specific gravity, and also their daily weight. This is one way you can determine if if the treatment is working, if they're gaining weight. Otherwise, as you lose all the fluid, you lose weight. All right. We want to encourage the patient to intake the amount of fluid. The intake must equal their output. We are monitoring their IV fluids, amounts for intake and output as well. Now, polyuria and polydipsia may signal a need for a higher dose of the DDAVP or the DI medication. So if the patient is urinating a lot still and they thirsty a lot, then a dose increase may be warranted. Drugs for DI cause water retention. It helps to hold on to the water. So this can lead to fluid overload. And so we must teach these patients to weigh themselves daily, same scale, every day, same time, same amount of clothing. If the weight is greater than 2.2 pounds with water toxicity signs and symptoms such as persistent headache, acute confusion, nausea, vomiting, then these patients should go to the OR, not the OR, the ER, and 911 should be also called. Now, when you think about the SIADH, so this is the opposite of DI. When it's essentially you have plasma osmolarity is low or normal, and it means you have enough fluids on board or hydrated well enough. Well, let me back up. So basically, if everything is working properly, all right, the ADH is working, the hypothalamus, the posterior portion of the pituitary gland, if all of this is working properly, of course, the osmolarity of these patients are going to be either low or normal, which is good. They're hydrated well enough. But with SIADH, essentially the negative feedback loop mechanism is broken, all right, and will cause vasopressin secretion to occur. When vasopressin, of course, is produced, then you're going to hold on to fluids. That's that. It's that kind of like. It works on the ADH. It causes the ADH to cause the kidneys to reabsorb fluids. All right. It essentially leads to the production of more ADH. And of course, this will lead to fluid overload and, of course, the fluid and electrolyte imbalance. And, of course, the sodium is going to be diluted now. See, in DI, the fluids are going to be concentrated because you're losing a lot of volume. But in SIADH, the sodium levels are going to be more diluted because you're holding on to more volume. So you have a dilutional hyponatremia. All right. Now, the increase in blood volume leads to increased kidney filtration. And of course, this is going to inhibit the release of the renin and aldosterone. All right. When you have this this inhibition of renin and aldosterone, and especially the aldosterone, there's going to be an increase urine sodium loss. Loss of sodium is going to be lost, and this is going to cause the body to go even more into hyponatremia. All right. You have to remember with the ROS system, sodium in water is retained and only kicks in when the system detects a low blood flow to the kidneys due to possible volume depletion. But when the body thinks it's more volume than what is needed, the ROS system is not going to kick in, and there's going to be sodium loss or excretion is going to occur. All right. And so, so you don't have enough sodium because you're kicking a lot of it out. You're excreting too much of it. Now, early signs and symptoms of SIADH due to fluid retention, it is going to be rather due to fluid retention and dilution of sodium as well, or hyponatremia. And these patients will experience things such as GI disturbances, loss of appetite, or such as loss of appetite, and nausea and vomiting as well. Now, we always want to assess these patients daily to see if they have gained weight. Because if the treatment that we're giving them, if we give them treatment and it still appears that they're gaining weight, then something is not working. All right. And so we have to do things like free water, not salt, is essentially retained without dependent edema. So you won't see the dependent edema in these patients. So with water retention, there's going to be this low sodium now. And so fluids are going to shift. And of course, it is going to shift into possibly the cells in the brain. And this will affect the central nervous system. And this normally occurs when the sodium levels reach roughly about 115, which is pretty low. And so then you can look for those symptoms such as lethargy, headache, hostility, and also deep tendon reflexes are going to be diminished as well. Right. These patients will also have a full bounding pulse. Remember, they're in fluid overload now, fluid volume overload. And this is due to the fluid volume, increase in fluid volume, as well as hypothermia, because there's now this dysfunction with the central nervous system. Remember, all that fluid is now shifting into brain cells as well, because the outside fluid is very hypotonic. And so the water will follow or go inside of the brain cells. And this is when you will begin to see some of the neurological signs and symptoms. There will also be, of course, water retention, which leads to decreased urine volume. And of course, if you're not urinating as much, then the osmolarity or the concentration of urine is going to be increased because you're holding on to all this fluid. Also, with water retention, the plasma volume is going to be increased. And of course, the plasma osmolarity is going to be low or less concentrated. Remember, you're holding on to all this fluid, and the normal serum osmolarity is between roughly 260 and 300, or 270 and 300. And of course, the osmolarity in the blood is going to be more on the lower side because of all the fluids the patient is holding on to. Now, when urine sodium levels increase, then the urine specific gravity is going to reflect that. And of course, if you test it, then the urine concentration is going to be very high of sodium contents. All right. Now, serum sodium levels, they can decrease as low as 110 due to fluid retention and the sodium losses. And this is when the patient is really in trouble, a lot of trouble, if this is not turned around quickly. Now, when someone does have SIADH, some important interventions are fluid restriction, intake. You don't want to add more fluid to the system. Also promote water excretion. We also want to replace the sodium because the sodium is steadily dropping. And also we want to interfere with the action of ADH, the antidiuretic hormone. We want to interfere with that action because as long as the ADH is working, then you're holding on to more and more fluids. And so there are drugs that can be given that can inhibit ADH production. Now, fluid restriction, let's see, so is needed because the patient has too much fluid on board. And the more fluid someone drinks, of course, is going to lead to more diluted plasma. And so we want to institute fluid restriction. The fluid restriction may be 500 to 1,000 milliliters per 24 hours. We also want to dilute tube feedings with saline versus water, and also use saline to irrigate GI tubes. We want to use saline when we mix drugs as well, when we have to administer medications through the GI tube. We want to mix it with saline, not free water, because the free water will cause more and more water intoxication, if you will. All right. We also want to measure the intake and output, the daily weight. A weight gain of greater than 2.2 pounds or more over several days would be concerning and should be reported as soon as possible. There's also frequent mouth care, which can be done by the UAP. Drug treatment with vasopressin receptor antagonist. In other words, we want to block the receptors on the kidneys, all right, so that the kidneys cannot respond to ADH. All right. Some of those medications is Vaptans, well, it's spelled V-A, V as in Victor, A-P as in Paul, T-A-N-S. One of those is called Tolvaptan, and it is PO. Also, there's one called Conivaptan, and that one is given IV. And is used to treat SIADH with the low sodium levels in the hospital. And this will promote more water loss without loss of sodium. So the sodium would be preserved more. Now, other interventions we need to think about. These patients are going to be administered hypertonic solutions, 3% saline. That's very hypertonic, all right? And this is given for very low sodium levels. And it has to be given slow due to the fact that it might worsen heart failure or fluid overload, all right? Because you're trying to reverse what is actually happening. They're losing sodium, and their sodium levels are really low. And so we're giving them this hypertonic solution to increase the numbers, but not too fast. Remember, the normal range for your sodium level is 135 to 145. All right. Saline is always better for IV fluids than water solutions. The latter can add to sodium dilution, and so we want to stay away from free water. Any patient, especially older ones with a history of cardiac disease, renal disease, pulmonary or liver issues, are at risk for pulmonary edema and heart failure. So we must prevent fluid overload in these patients. Now, signs and symptoms of fluid overload: bounding pulse, increased neck vein distension, crackles of the lungs, lung sounds, shortness of breath with increasing peripheral edema, also decreased urine output. And so we have to monitor these patients at least every 1 to 2 hours because their changes in their condition can deteriorate really fast. Now, we must also think about a safe environment for these patients because due to the low sodium levels and the fluid and electrolyte imbalance, neural changes can occur. And this is especially due to that osmotic shifts, fluid shifts into brain tissue. In other words, as the sodium, as the internal environment of the plasma becomes more hypotonic, it is going to shift into brain tissue, especially as the sodium levels fall, let's say less than 120. And of course, this will result in cerebral edema. And of course, this can also lead to seizures and changes in mental status can occur with these patients. Other neurological signs and symptoms might be muscle twitching, increased irritability, restlessness, seizure, or coma. And so again, we must observe these patients frequently, at least every 2 hours, or depending on what the orders indicate. We also want to decrease environmental noise and lighting in the room in order to reduce overstimulation. The more severe the SIADH, the more frequent neural assessments should actually take place. The flow sheets can assist in detecting trends and possible other problems. And so when you look at these patterns and things seem to be getting worse, or the trends seem to be going in the, to the adverse, then we know we have to do something. We also want to make sure that the bed rails are up, for safety. All right. Diabetic ketoacidosis and also HHS are other issues that are seen in complex health of these patients. As far as the etiology and pathophysiology of diabetes-related DKA, it is caused by a profound deficiency of insulin. It is characterized, of course, by hyperglycemia. There's also ketosis, acidosis, as well as dehydration. It is most likely to occur in people with type 1 diabetes. Now, DKA can be seen in people with type 2 diabetes in conditions of severe illness or stress in which the pancreas cannot meet the extra demand for insulin. But it is mostly seen in your type 1 diabetes. Some of the precipitating factors that will lead to DKA include illness, infection, inadequate insulin dosage, undiagnosed type 1 diabetes, lack of education, understanding, or resources, as well as neglect of health. As far as HHS is concerned, or hyperosmolar hyperglycemia syndrome, it is a life-threatening syndrome that can occur in the patient with diabetes who is able to make enough insulin to prevent DKA, but not enough to prevent severe hyperglycemia or even the osmotic diuresis, because the blood sugar is so high, it has an osmotic diuretic effect. So these patients, they urinate quite a bit. And also extracellular fluid depletion as well can occur with these patients. All right, because their plasma blood glucose levels are so high, they actually become very dehydrated, and so that fluid volume depletion because of the high glucose levels. HHS is less common, of course, than DKA. You see DKA more. And also, if you guys can take a look at table 48.17, it will provide you with a little more information than what I'm giving you. And it also occurs in patients over the age of 60 years of age with type 2 diabetes. All right. Now, as far as some of the management of both these conditions, as far as DKA and HHS, management is pretty similar. All right. We have to administer quite a bit of IV fluids. There's also IV administration of short-acting insulin. Electrolyte replacement is necessary. Assessment of their mental status, recording of their intake and output. Central venous pressure monitoring might also be indicated. Let us know what their fluid status is. Also, assessment of blood glucose levels, assessment of blood and urine for ketones, and also ECG monitoring. These patients will become hyperkalemic before becoming hypokalemic, and so we have to watch their cardiovascular um, um, system as well as the respiratory system. As far as initial interventions, we want to ensure that there's a patent airway, give oxygen via nasal cannula, or the patient might need non-rebreather mask depending on what their O2 needs are. We also want to establish a couple of large bore IV catheters because we may have to give tons of fluids. Also begin fluid resuscitation with normal saline solution, 1 liter per hour, until the blood pressure stabilizes and the urine output is between 30 and 60 mLs per hour. Remember, these patients, they're going to be severely dehydrated, so the blood pressure is going to be low, and they won't have adequate perfusion to their kidneys, and therefore the urine output is going to be low, and therefore they need a lot of fluid resuscitation. All right. We also want to begin a regular insulin drip, point units per K per hour. We want to identify if they have a history of diabetes, the time they last ate, and also the time and amount of when they took their last insulin is important information to have. Monitoring, of course, is ongoing. We must monitor their vital signs, their level of consciousness, ECGs, O2 saturation, as well as their urine output. We also want to assess for breath sounds, looking for fluid overload. Remember, we're fluid resuscitating these patients. They're getting lots of fluids, and we need to make sure that they're not going into fluid overload. We also want to monitor the serum glucose and serum potassium levels, especially once you give them insulin. The insulin will cause the high levels of potassium to, it will hide it in the cells, all right? And so this can cause these patients to become hypokalemic, all right? And so we have to give potassium to correct the hypokalemia. We also must give sodium bicarbonate if the patient goes into a severe acidosis. In other words, if the pH is less than 7.0. And we also may have to add dextrose to IV fluids for blood glucose levels that falls less than 250. We don't want the blood glucose levels to fall too fast. So sometimes they are placed on glucose, dextrose and IV fluids. Now, with HHS, it is a medical emergency, and the mortality rate is very high with this condition. And as I mentioned to you, management of HHS and DKA are pretty similar. In addition to normal saline and insulin administration, half normal saline might be indicated as well. These patients do require large volumes of fluid replacement because their blood sugars can be through the roof. I mean, well over 1,000 at times, 1,500, close to 2,000 or more. This should be done slowly and carefully. You don't want to just rush everything in these patients. You want them to normalize more slowly and normally. Now, patients with HHS are often older, and they may have cardiac or renal compromise. And so they will require hemodynamic monitoring in order to avoid fluid overload during fluid resuscitation or replacement. All right. Now, when the blood glucose levels fall to about 250 milligrams per deciliter, IV fluids containing dextrose are given to prevent hypoglycemia. Electrolytes are monitored and replaced as needed. Hypokalemia is not as significant as it's not as significant in HHS as it is in DKA. Low potassium is much more significant in DKA. Although fluid losses may result in milder potassium deficits that require replacement. But we're constantly monitoring these things at any rate. So that was a lot of information to take in, because there are many conditions that I try to abbreviate as much as possible. All right. Now, remember when I was telling you about the adrenal issues, be that a hyperfunction, hypofunction. In this case, we're more looking at hyperfunction, or Cushing syndrome is more of a hyperfunction of the adrenal glands. Now, the adrenal cortex steroid hormones have three main classifications, as you can see here: glucocorticoids, mineralocorticoids. Remember, that's your aldosterone. The glucocorticoids are things such as like your cortisol, and then you have your androgens as well: progesterone, estrogen, and so forth. Now, glucocorticoids regulate metabolism. It increases blood glucose levels, and are critical in physiologic stress response, how our body deals with stress. All right. Not having enough on board can actually kill a patient. So they're very important. And as you can see, the effect that glucocorticoids have on the system, the general appearance, integumentary, cardiovascular, GI, renal, musculoskeletal, immune, metabolic, and emotional as well. These are some of the effects that glucocorticoids have on these systems. Now, the primary glucocorticoid is cortisol. There are others, but this is the primary one. Now, your mineralocorticoids regulate sodium and potassium balance. Remember, that's the aldosterone. If it's a hyperfunction, then you got too much sodium being produced or reabsorbed. And of course, these patients will appear more swollen. And of course, you will likely have more excretion of potassium in this case. And so, again, place these patients on monitors. The primary mineralocorticoid, of course, is aldosterone. Androgens contribute to growth and development in both genders, and to also sexual development in men. The term corticosteroid refers to any of these three types of hormones made by the adrenal cortex. All right. So now the cortex of the adrenal gland produces these hormones, and when there is dysfunction, as in too much, hormones such as your glucocorticoids, your mineralocorticoids, your androgens, these will be seen in your again your Cushing syndrome. And of course, this is when you have too much of these hormones. But just think about with the Addison's disease, or the deficiency in these different types of hormones. They will have more opposite features than what you will see with Cushing syndrome. But many of the systems are, of course, impacted, as you can see in this list. And remember the example I gave regarding fluid and electrolytes, especially when you're dealing with the mineralocorticoids and the aldosterone. Remember, aldosterone is, when it is produced, it travels to your kidneys, and it causes your kidneys to reabsorb sodium, and of course water follows. In this particular case, the blood pressure will likely be elevated because sodium and water is being retained. With the deficiency type, or hypoadrenalism, you're going to have more hypotension um, with these patients. Now, something that is very interesting that I wanted you to see, um, this is what you will see in these patients who have Cushing's syndrome. With Cushing syndrome, it's almost as if you're giving them, think about the signs and symptoms you would see with a synthetic form of steroid. You're producing all these corticoids, glucocorticoids rather. And this is a very important image for you to keep in mind as far as some of the features that you might see, especially on the tests. Acne, the moon face. Remember, they are retaining all these fluids now. Sodium and water is being retained. You have increased body and facial hair. Think about the androgens, the weight gain. Think about the androgens, or rather the aldosterone. You have the purple striae, the pendulous abdomen, and look at the ecchymosis resulting from easy bruising, slow wound healing, thin skin and subcutaneous tissue, thin extremities with muscle atrophy, with Cushing's. This is Cushing's now. Supraclavicular fat pad. Then you have the buffalo hump. That's really important to remember. You have the red cheeks and the thinning hair, and their personality is also they don't list that here because it's not a physical characteristic, but very significant. These patients have quite a bit of personality behavioral issues. And folks, that is about it. That actually lasted longer than I thought, but much of that is because I tried to take the time to show you different things. It was a little over 2 hours, 2 hours and 20 minutes. And I really apologize for that, but I really just wanted to make sure that I provided you with some examples rather than just talking. And, I just think it's just very helpful for you all. Believe it or not, it's almost 5 o'clock in the morning. I didn't mean to stay up that late, but I had to get this done. So at any rate, go ahead and take a listen. Hopefully this will give you the information you need to help you be successful on your upcoming exams. And I'll try to get this out this weekend so that you'll have it, maybe able to listen to it Sunday and going forward. This is pretty much the last lecture, and so we don't have anything to lecture on Tuesday and Thursday, but we can do some reviews for the exam. So that's advantageous for us and for you. Anyway, you guys take care, and we will talk soon. Thank you.